All right, we're recording, and I'm going to hit start broadcast. Or somebody, oh, hold on, let me pull this in. I'm going to pull my screen up. There we go. And if somebody can do the hit the button. Oh, I can do it. I can do it. You guys ready?
Yep.
Okay.
Yeah.
Let's go.
The broadcast is now starting. All attendees are in listen-only mode.
Hi, welcome to the frustrating world of autoimmune arthritis with a feature of psoriatic arthritis segment. On our panel tonight is Tiffany Westrich, the CEO and co-founder of the International Foundation for Autoimmune Arthritis. We also have Meryl Pike from the, I closed it, the arthritis.
Secret Psoriatic Arthritis Business.
I'm so sorry, I closed that out on us. I apologize. We also have Tammy Brown, who is another co-founder of the International for Autoimmune Arthritis, and I myself, who am flubbing up here a little bit, I'm Kelly Conway. I am also a co-founder of the International Foundation for Autoimmune Arthritis. So we're going to begin by saying what drives awareness, education, diagnosis, and access to care. In this hour, we're going to discuss these frustrations and learn what is being done and what you can do to sort of tip the scales towards a better understanding of autoimmune arthritis. Now, frustrations of awareness, especially with the word arthritis, education in public, but in more health professionals, leading to a delay in diagnosis and treatment. What can we do? Anybody have any advice on what we can do to sort of help with the education of the public in terms of to help speed up our diagnosis of autoimmune arthritis?
Well, I mean, I think that one of the most important things is education. I mean, Morel and Tammy, I don't know if you agree with me on that or not, but I think that educating yourself is probably the most important thing.
I agree. I also think that we really have to look at reputable organizations. A lot of times I see things posted on social media, which social media is a blessing and a curse. It opens up the door to receiving some really good information, but also people will post anything without really checking to see if it is true. So I think it's really important to go to reputable organizations that give you information. Also, avoiding Wikipedia. Wikipedia is put together by the public, and there can be a lot of very biased or incorrect information. That's another thing we really have to look at. And then also, if your family and friends send it to you, look at the resource. Is it current? I get tons of stuff sent to me by family and friends, and it's always stuff that I've done 10 years ago and really didn't work, and I just thank them for their thought and consideration and thinking of me, and I just sort of hit delete because a lot of the stuff that they send is really quite old. It's new to them, but it's old to a patient who's been going through this for so long.
Or they send you things that are related to osteoarthritis or things that aren't autoimmune, or in our case with psoriatic, everything is sent to us that's rheumatoid. So there isn't that understanding. There's actually hundreds of types of autoimmune arthritises, and they are actually all slightly different. So it's about educating people that there is actually different types and that some of us have very similar symptoms and presentations, but in the end we will be different. And there is slightly different management and treatment available depending on what type you have. So I find that's one of the biggest issues we have. And that's probably the biggest one with healthcare practitioners. And being one myself, I find that trying to educate them into thinking outside the RA box or the lupus box or something that's more common than what we are is very challenging, because that's all they're actually taught in their university-based courses or what they predominantly see in a hospital setting or in general practice. So they don't even think that it could be something else slightly different. So if your RA factors come back negative, oh, you don't have arthritis. So without actually looking further past the clinical picture with some, you know, behind the scenes education that there's actually a bigger diagnostic set out there to look at.
And if that's the problem in the healthcare industry, who do have some minimal amount of knowledge in this area, imagine what it's like for the public who automatically think you should take an ibuprofen and you'll be fine. Or you should take, you know, some sort of over-the-counter medication and you'll be fine. And that quite often is, well, not quite often, mostly is not the case.
Have you worn your copper bangle yet?
Oh, and magnets. Magnets often.
Magnets, yes.
Oh, right. Gin soaked raisins. That's another one.
Not going to work.
Well, it was interesting, Kelly. You had mentioned that about that anything can be shared, and I am just such a big advocate of being careful of that. And I had written a article. God, I guess it was like 3 years ago now, but it was called "I Heard Unicorns Cause Rheumatoid Arthritis," and it was literally because to prove a point that anybody can say anything, and it can be believed. So I think that was a good point that you made about that about checking your resources. And then the other thing that I wanted to just remind patients when we're talking about the practitioners is that I think it's kind of a fine line between the self-education. It's so good. We have so many resources now that we can self-educate ourselves. But then there's that fine line. You don't want to go in and say, well, I know that I have this symptom and this and that, so you should be diagnosing me or treating me a certain way. I think we have to really be cautious and respectful of the degree and the background of the people who are treating us, but at the same time be assertive. And I just think that's really important. But I'm kind of curious what somebody like Tammy might think of that, because Tammy's a little more soft spoken, so I don't know. I don't know what she thinks of that.
Excuse me, we do have to point out Tammy has the name Tiffany Westrich for some reason.
Oh.
So just making sure that people realize you are in fact Tammy Brown.
I didn't even notice that. Yes, I'm actually Tammy. And yes, I am. I do tend to be a little bit more soft-spoken and a little more timid, and that has gotten me in a little trouble. We'll probably talk about that more later here on the during this presentation. I guess the way that I tend to handle it is I do try to force myself to be a little bit more aggressive with physicians sometimes, when I know that they are talking to me about treatment, and I know from personal experience that I've already tried that and it hasn't worked. I try to force the issue and say, but remember when we've done such and such, remember what happened when we tried such and such. And I try to use examples, or, if we do something similar to something we've done before, I say, but if we do that, isn't that going to be like this? And I try to ask a question that's similar, or I say, well, what do you think if we do this? Won't that be like this? Or, I try to keep asking questions and make them think about what might happen or what we've done before, and just keep them talking. I don't know.
Well, no, that's important. And, I just wanted to ask that because, I was diagnosed with seronegative rheumatoid arthritis. I know, rheumatoid arthritis back in 2009, but I was very atypical. So it was almost a default kind of diagnosis because the practitioner wasn't really aware, or the practitioners at the time were much even less aware in 2009, even though it just seems like yesterday, about these symptoms. And I had so much crossover. And since then, I've had a second diagnosis of axial spondylitis, which is a step above undifferentiated, but a step below ankylosing spondylitis. And I pushed hard for that. I literally wasn't going to leave the office, put it that way, until somebody listened to me, because they kept the practitioner assistant kept dismissing what I was saying and saying it's just your RA. And I, as an educated patient, was very certain that was not my rheumatoid arthritis. So it's just to want to reiterate that it's very important to go in educated with your practitioners, because they have a lot of umbrellas that they're trying to manage, and just do it in a way. And the other tip that I wanted to just mention, we have the health grades kind of written on the bottom of the screen. There are several websites like Health Grades where you can go in and you can rate those people, and you can look to see how other people rate them. So, for example, I had recommendations from my prior rheumatologist, And I looked those people up on health grades, and they had very low ratings from patients saying they didn't listen, they weren't diagnosed quickly, just things that we care about. So don't be afraid to go on and do your own research before you even step in the door to a practitioner. I think that's really important.
I think being proactive is actually up there with education. It's about knowing what symptoms you have and not letting someone dismiss them on you. And it's about knowing and keeping updated even yourself with research. On our Facebook group, I post a lot of the medical journals. I get access to them as a nurse, but a lot of our general public members have no idea how to get into them or can see them. So they're actually not accessing the latest information or exactly what is happening with the pharmacology side of our drug treatment. So I try and keep them updated on that. It may not necessarily be happening to them right now, but it's something they can keep in the back of their heads for when something else appears. We all know we progress. So, and progression just isn't in a linear fashion for us. Progression can happen across, I started with one autoimmune diagnosis and ended up with 10. We stopped counting now. I've got enough letters after my name. Exactly. So, it's about knowing that this is what can happen next, because everyone fixates on just the arthritis and they don't realise the systemic effect. And then they don't look at, well, like you, Tiffany, suddenly your RA evolved into something else that sits in partnership, and that happens with all of our diagnoses. And that's where I think the rheumatologists especially just focus on your primary diagnosis, and they forget that sometimes one of your side diagnoses is actually the issue you're presenting with that day. So that's where you need to be proactive and say, no, it's not my psoriatic today, it's my AS today,
and,
or it's my lupus, or...
Another reason why that was a problem was because I'm on I won't say names, don't want to do brand name. I am on a biologic that's working fairly well for my rheumatoid arthritis. That's why it was so clear to me, because it's not a drug that's been tested and approved for spondylitis. And the only thing that was working for me was very strong, like ibuprofens, pain type of things that they typically will use for a spondylitis. And it was just very clear. So like you said, sometimes making sure that we might have lesser symptoms because we're being treated with one of those diseases and it's helping that one, but it doesn't necessarily mean that it's helping the others. So.
And sometimes a new one arrives and no one even considers that you actually have a new diagnosis or a new presentation.
All right. Well, I think what that leads us all to is that I think all four of us have been faced with doctors who really didn't believe what we were saying. And it leads to a late diagnosis, and actually it's hard for patients to get referrals here in the United States. Many people have to get referrals to go see a rheumatologist. Many of our general practitioners don't know enough to refer us, especially, I would guess, for psoriatic arthritis. They might refer to a dermatologist for the topical treatment of psoriasis, but a lot of patients have reported that they were never even looked at for psoriatic arthritis until some up to 20 years later. So when we think about it, I know from my perspective, my diagnosis story, I actively remember developing symptoms when I was about 14, and it started in my knee, and it started with walking. By the time I was 19, I actually had surgery done on my knee. When they got in there, they found nothing was really wrong. When I was 22, it hit me again, and I remember I was running fevers. I could barely go to work. I was in pain everywhere throughout my body. And I remember the doctor called my house and told my family that I was healthy as a horse and that I just was suffering from a lot of stress. And I'll never, ever forget that. I apologize. My dog thinks I'm talking to somebody else, and she is actively putting her bones to keep her quiet. I admit it. So I was told I was healthy as a horse. So then the whole, I must be a hypochondriac. I must be, because they're telling me nothing's wrong with me. And it was
all in your head.
It was all in my head. I just couldn't handle stress. And my family thought that. Everybody thought that, because that's what this doctor said. And he was a lovely man. But 10 years later, it hit me so hard that I could barely walk. I could barely lift my arm up. I would leave the grocery store in tears because I couldn't reach up to get things off the shelf. So when doctors at that time are still telling me there's nothing in my blood, there's nothing wrong with me, I knew I was not the crazy one. I was thinking they were crazy. Because you see, you know, how can I fake inflammation? There is something seriously wrong with me. So I think the diagnosis I learned, I went from being a very passive person to doctor was very confrontational in a respectful way, but very much you have to listen to me. My life is ending as we know it right now. I need help moving forward. And it took a long time.
Mm-hmm.
So I think the journey to diagnosis is so different for many people, but you figure I was 14, I'm going to do like 30-some years ago, that all started for me. Okay, so it was really 20 years into when I finally had a rheumatologist who helped me.
It took me 31 years to get diagnosed. I was a juvenile presentation, and because I don't actually have psoriasis, so that really throws the whole clinical picture out of the thought process. And of course, psoriatic arthritis wasn't even recognised as a disease when I was 5. So that made it very challenging. I was the child who was just tired all the time. I was the fat teenager who needed to lose weight to get the pain out of those joints you kept talking about. I had my carpal tunnel released as a 14-year-old. Stop playing with your joystick on your computer. I was the student registered nurse who was studying too hard and had become the nurse hypochondriac. My mother was diagnosed with renal disease, so then suddenly I had, Munchausen's, where I was taking on her diagnosis, and there was really nothing wrong with me. And then I got the constant lose weight, better lifestyle, it's shift work, you're not eating properly, it's all in your head scenario, little knowledge is a dangerous thing, sister, And then finally I went into hypertensive renal crisis at work, and I had a cardiologist, anaesthetist, who said to me, rather having a manic episode or there's something seriously wrong with you. And intensive care showed that there was something quite wrong with me. I finally got to see a rheumatologist when I said, someone said to me, so what do you think's wrong with you? And I said, well, for the last 10 years I've been telling you I have autoimmune and no one listens to me. I finally got to a rheumatologist who sat down and said to me, oh yeah, there's something interesting, but go away and lose some weight, you'll feel better. And I said to him, I think there's something more significant going on. I've had symptoms for all this time. I said, here, I've written my top 3. Psoriatic arthritis, lupus, and then RA, seronegative RA. And he says, well, I'll put that in the file and I'll send you for a bone scan to shut you up. So he sent me for a bone scan, and he actually came over because the radiologist rang him and said, I've never seen someone with such diffuse systemic arthritis in someone her age before. Come over and see her. So it's a long-running joke now with him that, I made him eat a lot of crow with a lot of tomato sauce, saying, like, you were wrong. And, of course, I diagnosed myself. So here I am, 47, and, I've had this for over 45 years, but really I've only been on treatment for 15 to 20 years because no one believed me. And I'm a healthcare practitioner and no one listened. So from a general public perspective, it must be horrific. And I hear that so many from our Facebook site members, nobody listens to me. And in fact, last night we had a new member join, and she said, look, I've been hearing about this thing called psoriatic arthritis. She said, I think I have it and no one wants to know about it. How do I go ahead getting someone to talk to me? Mm-hmm. The issue in Australia is, yes, GPs know all about RA, but they don't know about all the other autoimmune arthritises. And then comes the issue of access to rheumatologists here. It's actually the smallest specialty available in Australia. So some states don't even have a rheumatologist like Tasmania. They fly one in. So in our rural areas, because obviously we're a very big country, certainly don't have access to healthcare and rheumatology. So they've got to come into the cities, which then impacts on how many patients a rheumatologist can see. So
we have that problem with pediatric.
Yeah, well, we don't even have pediatric rheumatologists. We just have rheumatologists.
Yeah.
So from that perspective, access. So GPs aren't going to refer because access is so limited. They don't want to waste people's time. Mm-hmm. But they also won't do all you can't test for psoriatic arthritis. That's the other issue. We don't have an RA factor or an ANA, so we're actually very hard to diagnose from that perspective. And only this year has psoriatic arthritis without psoriasis been actually medically recognised. So, we're a rural different kettle of fish in some respects to some other autoimmune diagnoses.
Yeah.
But it's a challenge to get heard.
Yeah.
Tammy, would you like to share your story of diagnosis? Because it's actually quite interesting too.
Yeah, I'm not sure that it compares to what Meryl has gone through, but it definitely adds to what we were talking about before, especially to me and my being soft-spoken and probably not pushing nearly as hard as I should have. But in the beginning, mine started because I went, well, I'm going to say it started probably in 1994 or 96. I just started having one infection after another, kidney infection, kidney stones, and then just all kinds of upper respiratory infections. And as we all know, rheumatoid arthritis and autoimmune arthritis, they're inflammatory illnesses. They're connective tissue disorders, so everything can be inflammatory. So nobody was paying attention to any particular area. I was just getting infections everywhere. But in about 1999, I believe it was, my feet got my toes were just, they were mangled. They were all 90 degrees, sideways, all over each other. And I had to go in and have surgery on both of them. And I was a runner. I'd been a runner since high school. I ran like 5-6 miles a day. And I put it off to the last minute because I didn't want to stop running. Mm-hmm. So I didn't go in to see a doctor until I absolutely couldn't stand the pain anymore. I was even bringing fuzzy slippers to work so that I could take my shoes off and put my slippers on. But I went in to the orthopedic surgeon, and when he saw my feet, he was so amazed at how much arthritis was in my feet that he actually called in his colleagues because he couldn't believe how much at my age arthritis was in my feet. But he was saying, oh, it's got to be because of your running. You know, you ran all these years, but that's got to be what it is. And no one ever gave it a second thought. They just did the surgery on both feet and sent me out the door. And then I continued having one infection after another. So my regular doctor said when I kept having sinus infections and strep throat and everything, well, it's got to be from allergies. So he put me on allergy medications, and you know, it just went on. And then finally it started getting worse, and I started having more joint pains, and I had some sheared ligaments. When I ran, I sheared some ligaments off my ankle, and it went on for another 5 or 6 years before finally my internist, a light bulb went off when I started having pains in my joints in my hand, and she said, you know, we probably ought to test you for autoimmune disease. And I had a really high rheumatoid factor.
Can I just stop for one second, Tammy? I'm sorry to interrupt. We have a lot of noise coming through, and I'm not sure where it's coming, but it's kind of distracting from what you're saying. So I'm going to ask that people maybe not be typing right now or playing with papers. I'm not sure where it's coming from, but just so we can see if that is what the problem is. I'm sorry, Tammy. Please continue.
Okay. So I got into the rheumatologist and got diagnosed with rheumatoid arthritis, but at the same time I was told right away that I had a lot of crossover symptoms for lupus, and that continued all through my diagnosis, and treatment. I later switched to another rheumatologist, and she also told me that I had crossover symptoms. And even though I ended up later, unfortunately about 5 years later, they never were able to stabilize me, and I ended up having to go on permanent disability. I still, even with my treatment, I still kept having issues, and I kept pushing and asking, you know, I just feel that there's still more wrong. should we do more testing about the lupus, because I knew that I was having symptoms like malar rashes and other weird rashes and other things that were
fun stuff.
Pardon?
We get all the fun stuff.
All the fun stuff. And I knew that they were lupus-related symptoms, and she was telling me, well, it really doesn't matter anyway, because I'd be giving you the same treatment regardless. So she didn't do any further panel, the regular, the ANA panels, or no further testing for lupus. She just said, I'd be giving you the same treatment anyway, and kind of blew it off. So that went on for a few more years, and finally, long story short, I just continued to get worse and worse and worse. My health was declining, and this past year I changed rheumatologists, got to a new rheumatologist, and by that time I had developed a heart arrhythmia. And the first thing this rheumatologist did, as he went through my records and all the panels of tests that he put me through, first thing he realized was that I do have SLE lupus and I'm in third stage kidney disease. So I really, really, really should have pushed much harder. So that was my mistake for, letting that go on as long as I did, because I knew. So that's a lesson that we need to learn. We know our bodies better than the doctors do, and we need to educate ourselves, and we know these symptoms, and if we know that these things are going on and we're writing down the things that are really bothering us in between our appointments, take those things in and tell the doctor, hey, I'm really having a problem with this. I'm really having these rashes that look like malar rashes. Take the pictures in, take pictures of them when they happen, and show the doctors.
Exactly.
Give them proof of what's going on. Don't let them just blow that stuff off. I learned my lesson. I'm not going to do that again. So.
That's exactly true. And that brings us to what the delay in diagnosis really does for people. Tiffany, would you like to address that a little bit, delay in diagnosis?
Well, as far as diagnosis goes and delays, let me just quickly cap on that, if you're having issues and you're not getting the answers that you want, the best thing probably for you to be able to do is find a second opinion, find another doctor if it's possible. I know healthcare systems are different, but if somebody's not listening to you, it's probably not the best person to have on your team. So that's probably the most important thing, because as we know, a delay in diagnosis is a very dangerous thing, because all of these progressions, regardless of which disease it is, one thing that is similar is they're progressive, and whatever happens isn't reversible. So it's just extremely important if you can't get somebody to listen, try to find somebody who does. So that I just wanted to make sure I pointed that out.
Yeah, so let's say we get a diagnosis, but there are other obstacles, such as the access to the right treatments. For example, when Tiffany said if you have a doctor who's really not listening to you, like Meryl said, there's very few rheumatologists in certain rural places. That is a huge obstacle. Mm-hmm. Does anybody have any thoughts on other obstacles that sort of impedes someone's ability to access care, or any suggestions as to what they can do? I know one of my suggestions is often to see if there could be a consulting doctor, that if you're not very close to a rheumatologist in your area, I've met people who drive across 3 states to get to a rheumatologist because they live in such rural areas that it's a 9-hour drive. So I think what they've been doing is their general practitioner sets up conference calls with that doctor, and that doctor does the physical exam, and then they consult with the rheumatologist via either video chat or on the phone. I don't know if that's really the best thing to do, but I think telepractice is going to become more popular as technology takes off, and I'm hoping technology can maybe help patients get more help in the future. Does anybody else have any other thoughts?
It's quite big here in Australia because of our size and our remoteness. So we actually do a lot of what we call e-health. So especially in rural areas and regional areas, we have centres that patients can go into, and they do teleconferencing with their rheumatologists or other specialists. I live in a large regional centre in Australia, and I've even had teleconferences in with a former rheumatologist that I had in Sydney, with my rheumatologist where I am now. So I actually had a double, appointment going at the same time. So we actually use that. Well, one diagnosed me, I moved, and one cares for me, and my current rheumatologist trained my first rheumatologist, so they have a professional link as well. Wow. So, and especially in the last few weeks when I've sort of done something that's a little bit right out of the pages of miraculous, everyone's very curious about what's going on. So I get a lot of teleconferences and a lot of contact at the moment. So we do use technology a lot here in Australia. We all our scans, everything are sent via internet now. So you don't need to take a physical scan. Your specialist sees it before you do. You can even have them sent to your home address as well. So I get to see my scans before my specialist does. So that's where I have a little read and I go in and say blah, or I can text him, I can call him. So we're using technology quite a lot. So
that's very encouraging.
Wonderful.
That's very encouraging. I know I can see my medical records as soon as they come through, which is good. But I think the fear with that is I don't always know what they mean. And I think sometimes I find people contacting me and they fear the worst. And I'm like, you just got to wait to talk to the doctor. You can't just look at it and diagnose yourself. Anybody else have any thoughts on obstacles?
Well, what I think the other part, that's one whole section of access is obviously what we were just saying, access to being able to communicate and even be seen. But then and it's different. And I know there's other countries, and Marel is going to be able to talk about that more. But something that's really big in the United States is access to care in general. You've got what's called step therapy or fail first, and you might finally get this diagnosis, right? You go, oh my God, I finally got it, and then you don't have this access to the treatment that you and your doctor believe is the best for you, and you're forced to try a different medication before the one that was recommended. And if you fail it, then you can move on to the next one. So in doing that, you don't get the right treatment necessarily for you immediately, and then you've got that delay. Like the American College of Rheumatology and EULAR both agree that treatment should start, best case scenario, within 6 months from onset. I mean, I feel that's so unrealistic. But especially when you add this access issue to it. So, that's a whole other issue that we could spend hours talking to, but that's another obstacle we have to factor in. And I know, Morale, did you have something to add for Australia?
Well,
in Australia,
she waited 30 years from onset.
That's right. If these drugs weren't available then. The issue we have with Australia being a public healthcare system, we do have a private health insurance system as well, but it's the public one that actually provides us with our medication. We actually have so many hoops to jump through after diagnosis. So it doesn't matter what my rheumatologist says I need to be on. Obviously, biologics are the first line gold standard for us. We actually have to go through a trial and failure phase of all the DMARDs that are available for us. So you actually have to prove that you failed at least 3 DMARDs for us. Now, for me, methotrexate, I'm anaphylactic. That was really quickly. Within 4 hours, I was intubated in intensive care. So, failure. Arava, I ended up with pneumonitis, but that took 4 years. Imuran suppressed my immune system, so before they got the bone marrow transplant ready, I was deemed a failure. I finally got onto Humira as a biologic as a first trial. I had to go through government approval, which took nearly 3 months, and so I was on no treatment while I was waiting to access the biologics. I failed Humira within 4 weeks. So once again, I had to go right back to scratch again, and we had to wait, and then I could progress on to Enbrel. The issue then is with Australia, we have only certain drugs approved for certain diagnoses. So because I have a psoriatic arthritis diagnosis, our FDA and our government says I can access 4 biologics only, but I'm only allowed to trial 3. And if I fail those 3, I'm booted off the system for 5 years, which means I have no access to medication for 5 years.
Wow.
I've just gone through that process of failing my 3rd biologic, and I was removed from the system for 5 years. So I can have no DMARDs, no biologics, no treatment whatsoever for 5 years. And the issue with that is, being someone who's no long-term diagnosis, our legislation, for want of a better word, hasn't actually factored in us long-termers. It's only been there for the length of biologics without realising that some of us have 30 years of damage before we even get there. So access for drugs for us is really quite significant. So I'm campaigning against Canberra about their decisions. I haven't gone to the Human Rights Commission about access to medication because constitutionally I have an access right to medication. So we're challenging things at high court levels now. So that's how serious it gets here for us. So I know you guys have issues with insurance companies. We don't have that. I've got to fight the government directly.
Wow.
Wow. Well, it's very interesting, especially hearing the perspective from around the world, and even the perspective. Tiffany, Tammy, and I live in 3 different parts of the United States. So it's you know, Tiffany and I are very close to large cities. Tammy's in a more rural area. So it's very interesting to hear all the stories. And I think as being part of IFA, we've heard thousands of stories over the years. But right now I see that we do have a few questions from some of our listeners, and I thought we would take a moment to answer some of them. One that has come up is, how do you explain to others that, if I could pull it up all the way, how do we explain to people that you have more than ordinary arthritis? And again, we never want to say that arthritis is not very serious. My father suffers from severe osteoarthritis. It's a serious, serious condition. But how do we explain our systemic arthritis as opposed to osteo or degenerative arthritis? Does anybody want to answer? Anybody have a good answer for us?
I start with the conversation that I don't have arthritis, I have an autoimmune disorder. And the moment someone hears the word autoimmune, they actually listen. And then of course I throw in what we call the big C card, which is I'm on chemotherapy for my arthritis. And they go, what? Chemotherapy for arthritis? Don't you just take over-the-counter Voltaren or use some gel, or, you know, your copper bracelet or the mango extract, or, you know, stand in the moon for 4 hours, or, you know, and I go, no, I actually take, you know, long-term, lifelong chemotherapy for my arthritis, and that changes the whole context of the conversation.
Right. I do something similar. I do something similar to that. If I will say the autoimmune, and I stress autoimmune arthritis. That usually gets their attention. If it doesn't, they'll do the typical, "Oh, I have that too," or, you know, something like that on my knee.
My grandma has that.
And then my usual response to that is, "Oh, so you have degenerative arthritis." Because the autoimmune, I can't have it just in my knee. It's systemic. It's full body, and that always gets their attention. I've never once had somebody just let that blow over their head. So I find if you ask a question, or, "Oh, well, what kind of arthritis do you have? Is it degenerative or is it autoimmune?" And if you put that back on them, they almost have to think about it. So that's how I usually solve that.
I do something very similar. You know, my arthritis has damaged my renal artery. Did yours do that? You know, you know, unfortunately, some of the medications we take also cause damage.
Right.
It's really a very serious decision to pursue a certain medical treatment. But I think making it clear that it is an autoimmune disease, that it is systemic, that it's not easily handled by simple over-the-counter medication is extremely important. I still get, "Oh, you're too young for that," and to which I always reply, "Well, really, my best friend's son was just diagnosed, you know, last year, and he was 13. It's rheumatoid arthritis, psoriatic arthritis, lupus. They are not They're not your normal types of arthritis. So
I will actually, to add to that, if somebody says you're too young, I'll say, well, I may be too young typically for degenerative arthritis, but you can be born with an autoimmune disease, and so it's the same kind of thing. Just throwing it back and being very matter of fact, like, well, what are you talking about? So
I do that, and then I add, so you know how painful your arthritis is, so imagine what it was like for me as a 5-year-old with that. And they just look at you and go, oh. So, you know, when they start talking about, oh, I've got arthritis too, and I go, yes, it's sore, it's painful, you know, it's debilitating. I understand that, but, you know, you're 80 or you're 65. I said, try having it as a 5-year-old and no one listening to you.
Right.
So that really throws them back to, wow, this is different because I didn't have that at 5. So.
Right. All righty. Tiffany and Meryl, would you like to talk about the program that you are doing?
Yeah, let me brief this. This part of the presentation is sponsored by Celgene. They are also a sponsor of World Autoimmune Arthritis Day, so thank you to them for making this possible. They have approached an International Foundation for Autoimmune Arthritis and asked us if we would do a special focus on psoriatic arthritis, and of course we accepted. So we came up working with them. We came up with learning about patient struggles, calling it LAPS, and we thought, well, that's kind of clever because it goes in with World Autoimmune Arthritis Day this year, which is an online race around the world. So that's where that came from. And the focus being something that we also could take the information and relay it to other diseases as well, because even though, like we mentioned earlier, there are some similarities, there's obviously some things that are very different. And so we want to kind of focus on those differences here. And we've already talked about some of this, so I don't want to be redundant. But what we did is I went to Morel and I said, I was introduced to her actually by one of our volunteers and asked if her group might be interested in talking about some of their most pressing issues. And why don't you tell a little bit about how that went?
Well, I have to say we had an overwhelming response. We're a global group of just over 1,200. We started as an Australian group, but we started getting international requests to join on Facebook. So suddenly we became an international group. We decided to become a closed group so that what stays on Facebook stays on Facebook and not through everyone else's feeds. That's also opened up very big channels of communication and education processes for us. I just posted as the facilitator, I posted to the forum, this is, you know, I've been approached by Tiffany and they'd like to hear our side of the story. Well, I had over 400 responses in about the first hour. So they were very, very keen to be involved. I had a lot of private PMs sent to me and emails for people who didn't want stories on Facebook, which I'm willing to accept as well. And we collated all the ideas and here we are today. So thank you for inviting us.
And so she came back and she gave me kind of a highlight of some of the main issues that patients with psoriatic arthritis were coming up with. Some of them, again, similar to what others experience, regardless of the diagnosis. But I've kind of incorporated some statistics that were done specifically on psoriatic arthritis, so we can see. One of the things that was mentioned several times was a frustration of being not only the delay in diagnosis, but misdiagnosed. And I found that really interesting because Morel, if you could elaborate just a hair on that. I thought it was interesting because I think the public, and from what I've read from a lot of the things that your folks had read or submitted anonymously, was that it's so misunderstood because people think it's just skin and it's joints. You know, same thing with RA, or it's just joints or whatever. So if it's like that underdiagnosed, that seems to people who don't understand psoriatic arthritis, very large number. So why do you think that people are so underdiagnosed?
because there's no definitive testing for us. So we can't go, look, here's an RA factor, here's your ANAs. We can't actually have a blood test. The closest thing we get to will be the HLA-B27s, but as you know, that's also for all the other spondylolytic arthritises. So, and it's genetic, you don't always carry it. So it's not even close to telling us we have psoriatic arthritis. The premise that we all have psoriasis is also now being disproven. A lot of us don't even have psoriasis or develop psoriasis later on in the disease, right. And that's actually when we start getting a diagnosis, is when the psoriasis appears. So I didn't have psoriasis until I was in my 40s. So here I was, a 5-year-old with psoriatic arthritis with no psoriasis and no family history either. Mm-hmm. So I'm the first one in my family with this disease. So there's a lot of that, oh, if you've got it, someone else must have it. Well, no, I'm a genetic aberration. I can't, explain where mine came from. And so it's always been overlooked. So most people, they go in, those with active psoriasis, people just think it's skin deep and off to the dermatologist. Mm-hmm. The dermatologist doesn't think about the rheumatology side of things. And I've even had students that I've seen with really bad psoriasis, and I go, so how's your joints? And they go, oh, they're a bit sore. And I go, well, have you been to a rheumatologist? And they go, why? Because right. No one actually even tells people with psoriasis that there's something called psoriatic disease, and right. You can get an arthritis out of this. So dermatologists aren't even, letting their patients know if they've got skin issues that, hey, there's something a little bit more sinister that can come out of this, and the chances of you getting this is, still 15%, which is quite high within our population group. Mm-hmm. So no one's actually telling people, well, you need to keep an eye on your joints, you need to keep an eye on your skin. But then, of course, everyone goes, oh, it's just a joint disease. Well, yes, we're a little bit different in a joint disease. We're actually more connective tissue. Mm-hmm. So we're the tendinitises, the entheses, we do the stress fractures and things like that. We do get the deformities, the swan neck deformities and that in our hands, but it comes later in life, mm-hmm. or later in the disease process. So we actually don't present as physically obvious as everybody else. So we're actually a little bit of the silent subclinical group. And that's why it takes so long for us to be diagnosed. And yes, we all go through we'll just test you for, your rheumatoid right. factor. No, it can't be that. Go away, lose some weight, you'll feel better. And the biggest one we get is, we understand you've got pain. Here, take some more painkillers and it'll go away, without actually looking at what is causing the pain. So no one actually looks at the reason why we're in pain, or why we've got a mobility dysfunction or something like that. Most of us present with acute Achilles tendonitis. So mm-hmm. a lot of it is, oh, well, you're a runner, you're an athlete, or, you're wearing high heels, or you've got too much weight on. They look at lifestyle and not actually disease process. So it takes a long time for us to get diagnosed, unless there's a family history and someone goes, oh, my mother had psoriatic arthritis, right. Then what's my chance? Right. Or now we're starting to get a little bit with things like social media, people are starting to realise we're out there.
Right. That's really interesting, actually. And, I'm throwing up a few more, some slides that were provided by Celgene talking specifically about psoriatic arthritis. And you can see on the second column that they mentioned some of what you said, Morel, about the symptoms being a little bit more than skin and joints. So I thought that was really interesting that this particular analysis that was done brought that up. Something that I wanted to just quickly, I know we're running out of time and we have some questions here, but so I wanted to, let me go through here. I wanted to ask you specifically, Morel, there's this whole, we've gone through the diagnosis, we've gone through the referrals, we've gone through the issues of access. Now we can get the medications, and now we're hitting this wall of fear. And I know that this is something that is in all patients. So Tammy or Kelly, please weigh in too as you wish. But this specific statistic was, some find that the therapies they cause more burden. Then you've got the issues of the fear, all the side effects, what's going to do to me long term. I'm interested specifically, Morel, because you've had it for so many years. I always find that the perspective is a little different than somebody who's recently diagnosed when it comes to fear of these medications. What all of you, I guess, has addressed this question, we'll kind of wrap it up. What are the pros and cons of doing a full treatment plan, and what is the fear? How justifiable is the fear, and when the end result could be?
We have a bit of a saying on our site, it's fear the disease, not the drugs, because without the drugs, you've got no hope. It's going to progress, and your life will be very different and very altered and short. So, and I think that's the big thing we stress to people, that even though this isn't what we would classically call a terminal disease, it certainly is a life-shortening disease without treatment. And that's just not from a physical perspective. You know, depression and mental health issues come very strongly with all autoimmune diseases, and specifically with us as well. So it's about, you know, preventing suicides and you know, addiction to drugs that we don't need to be on, by having better access to medication and treatment. I usually tell anyone who's starting the first time, yeah, look, I remember the first time someone said to me, here, go home and swallow methotrexate. And I'm sitting here going like, this is a cytotoxic drug. And I had to do it in my kitchen alone. There was no one at home. There was no one supportive. It was like, go home and take some poison, and it's supposed to make you feel better. Well, in my case, it was an ambulance trip and a tube down my throat in intensive care. It wasn't exactly what everyone was planning.
Right. It wasn't the magic that you were promised.
Yeah, that makes trying other drugs very scary, even for someone at that stage. I had 20 years clinical experience, and I was very senior in my career. So for me to go home and do that was frightening, let alone someone who's just been diagnosed, let alone when someone says, oh, we've got this new treatment called biologics. I said, oh, that's just the big fancy name for injectable chemotherapy. And they went, yes. So they make these nice little names, but when you actually look at what you're actually taking and the impacts of what that is, you know, people don't realise I can't drink water out of a tap. I can't eat bain-marie food. I've got to be careful if I eat sushi. You know, people don't realise there's limitations on things. I can't be immunised, which took me out of clinical practice here. I travel the world whenever I can, but I take a high risk in doing that, being immunosuppressed, let alone all the fun with going through customs and travelling with things that needs, you know, being cold. And but actually most people are helpful, but people just don't understand the impact, not only the psychology, but also the physical impacts of these diseases. I watch so many times in our site the troubles everyone has with methotrexate, yet everyone says it's the cure-all drug, but they're always got side effects. Their hair falls out, they get mouth ulcers, the fatigue, the nausea, and it's supposed to be making them feel better. So, and then when that fails, here, try another poison. So it's actually really challenging. And then, of course, when you get to injectables, no one likes to put a needle to themselves. And I remember I was literally sent home and told, you're a nurse, you know how to self-inject. Now, I've given hundreds of needles. I've never given one to myself. But you'll be fine.
That's different.
Go home and do it yourself. You know, oh, and if you're anaphylactic, make sure you have the ambulance ready. You know, like an ambulance takes an hour to get to me where I live. So it really wasn't an ideal situation. So I think it's important that we prepare patients for medication. And I think we need to tell them what the side effects are and what to expect. But the other one we also stress on our site is we all respond individually. No one has the same response to any medication.
Exactly. Very important point.
That's very true.
And it's a failure for others. And the other one we talk about is, don't always jump to biologics to begin with. You can actually be managed on something lower, which gives you a chance to have another level of treatment when you need it if you do progress.
Right.
So,
and if I could just interject here, because we do have to wrap this up. I think the other thing, there's a lot of misconceptions about these drugs. I have a friend who was recently diagnosed with psoriatic arthritis, and her response was, no, I'm waiting on injectables until I get bad. And my response was, it will prevent you from getting bad. But again, it's not my place to tell someone that you should do this. I can only give them from my perspective. But I have to say, this has been a very intense. I feel like we covered a lot of topics. We talked about access to care, diagnosis. We talked about education and public awareness. Does anybody have a final thought for the night before we wrap it up?
I know that we don't have a whole lot of time for questions, and I can't really see from my. I
do see one. It says, how does PSA differentiate from RA or OA as far as diagnosis goes? Well, rheumatoid arthritis, there is seronegative, but there is, it can show up in your blood. Osteoarthritis is more bone on bone and degenerative, and it develops over time after use, where, and Morel can probably speak better to it, but psoriatic arthritis is, Morel, do you want to just give your...
Essentially, it's clinical presentation. So you'll have swelling in your fingers, Achilles tendonitis, plantar fasciitis. You might have carpal tunnel syndrome. It's more a connective tissue than an actual joint thing. Joints eventually do become involved, but we have, and the fatigue is another big one for us. So it's and pain, obviously, like everybody else. But we're more diagnosed that way.
Right. All of the autoimmune arthritis diseases are infamous for the brain fog and the fatigue.
Yes.
I think that's something that
and muscle, actually.
Right.
All this, all.
Exactly. Well, I think that is all the time we have. I think we have answered most of the questions. There's one more here. Someone is asking, they missed the beginning of the webinar. Will it be made available later?
Yes, I can answer that. We are recording it. So this one and the other 4 that we're doing during World Autoimmune Arthritis Day will all be downloaded, and we'll start posting the ones that we had today tomorrow. So tune into the Facebook page for World Autoimmune Arthritis Day.
Your voice right there.
Mine?
Can you guys hear me?
Yes.
Yeah.
Yes. Okay, I can no longer hear you guys for some reason, but I will thank Tiffany Westrich, the CEO and co-founder of the International Foundation for Autoimmune Arthritis. We have Morel Pike from the Secret Psoriatic Arthritis Business, and we have Tammy Brown, even though her name says Tiffany Westrich. We have Brown from the International Foundation for Autoimmune Arthritis. Now I can hear you all again. I am Kelly Conway, and I am also a co-founder of the International Foundation for Autoimmune Arthritis. We thank everybody, all of our panel, for participating, and we especially thank all of our viewers who asked some really lovely questions, and you can watch us again. This will be posted soon, and that, I believe, is it.
Okay.
Thank you for having us.
Everyone.
Thank you.
It was nice meeting you, Morel.